Chapter 20, The Shaping of Inventory Systems in Health Services. Initial chapter by Jan de Vries from University Groningen and Karen Sprens from Hanken School of Economics. This is a summary of their chapter from the Handbook of Healthcare Delivery Systems. This chapter is very high in its overview on how to design inventory systems, and the big takeaway is that although there are many mathematical models in industrial manufacturing for inventory systems, these fall apart at times when used in healthcare as there are more stakeholders involved within a hospital and they seem to have conflicting viewpoints. If you're looking for a practical piece on inventory system management, specifically two-bin Kanban systems, which are really perfect for hospitals, I wrote one 2 years ago, which can be found by searching Stocking Hospital Supply Rooms, two-bin Kanban. The chapter authors state that, quote, despite the fact that hospitals carry large amounts of a great variety of products, studies suggest that healthcare organizations still pay little attention to the management of inventories. They quote in the chapter approximately 10 to 18% of net revenues in healthcare being regarding in inventory costs. And I suspect they're looking at total healthcare expenditures because the statistics I have heard as far as hospital budget allocated to supplies can be up to 1/3. The chapter says there's really three things you want to look at with an inventory system: how much to order, what are the costs to order the supplies versus to stock the goods, and what inventory system can manage these above processes. And again, they go into some examples of mathematical models. A very simple one is the economic order quantity, EOQ, which is the quantity that minimizes the total holding cost and ordering costs. There's other ones such as the economic batch quantity, EBQ, which they admit is a flawed system, but it tries to look at the cost to produce a batch of goods, to hold that batch in inventory, and then the total annual demand and annual production capabilities. But ultimately, these fail to account for that qualitative complexity in healthcare systems. And part of that, again, comes from the stakeholders. You have clinicians, finance, administration, pharmacy, industry, IT, and the general politics of the organization. And each group has different levels that they may desire to want stocked. Some groups may prefer speed and availability of meds, while other groups prefer reducing costs to a bare minimum. And so this all plays out with further complexity of who's responsible for paying for the capital tied up in these inventory supply chains. The chapter defines two terms: open stock, which is the stock dispensed to a patient, and closed stock, which is stock which comes from the central supply to a unit, a ward, or a department. All right, into part two. They identify 4 areas where decisions often need to be made with inventory system management. The first is the physical infrastructure. How many and where are the stock points? And this is going to be determined based on how goods are used in the hospital and how goods are delivered and supplied by the suppliers. The second point is the planning control systems. The stock planning is this balance again of timing of stock refills and the quantity of the refill. And this is influenced by a particular good's demand, the uncertainty of its usage pattern, and the critical nature of the good always being in stock. We move into 3, information systems, and these help track and plan hospital inventory. Unfortunately, many hospitals, their different information systems are not integrated, and this provides an incomplete and delayed picture of product usage. And finally, the organizational embedding. And this is the fact that, again, there's many stakeholders: pharmacy, lab, clinicians, administration, finance, IT, and they're involved in the hospital inventory system, and they often have conflicting interests. And so trying to get as many stakeholders as early in the inventory design or redesign process is helpful. The chapter ends with an example from the Dutch hospital. It was done in around 2006 to 2008 in a mid-sized 400-bed hospital. That place employed about 150 people in their inventory system. Some of the interesting takeaway statistics were during the 6-month analysis phase, they discovered that 43% of the total stock levels were below the minimum safety level. And these low stock levels lasted on average 20 days. And 16% of time, stock almost ran out and then had to be rushed ordered. The authors tried to find the root of these problems using their system from earlier in Chapter 2. So under physical infrastructure, they said there were too many stock points. Under planning control, there was fragmented storage and ordering. Under information systems, again, they had many platforms not connected. And under organizational embedding, the pharmacy in this institution was thought to not be as transparent on how they approach stocking. All right, that ends this chapter. Again, I highly recommend, if you want a practical inventory management advice, the article Stocking Hospital Supply Rooms, 2-Bin Kanban is very well read. And I had a lot of fun writing that one 2 years ago. You may want to check it out. And although it's specifically targeted at hospital supply rooms, the 2-Bin Kanban system can be used in many places. I know people who have read the article from backgrounds in agriculture or in orthodontics, and it's a lot of fun, actually.